Interventions with a King. Discussion and commentary based on articles from Jack, Cardiovascular Interventions.
Hi, David Moliterno with Jack Cardiovascular Intervention, and I'm joined today by longtime friend Dr. Paul Armstrong, who's from Edmonton, Alberta. We're going to talk about a manuscript upcoming from Drs. Kadakia and Sirica with the Timmy and Duke Cardiovascular Research Institute colleagues, and what they've done is pulled together a huge amount of data from the ACC NCDR Action Registry looking at anticoagulants among patients with an acute coronary syndrome. So, Paul, like I said, a huge amount of data. Give me some of your thoughts. What did they look at, and what kind of observations did they make?
Good to be with you, David. I feel kind of like looking in the rearview mirror as we go forward with this, as you say, over 100,000 group of patients, about a third of which had ST elevation and about two-thirds non-ST elevation myocardial infarction, studied between 2006 and 2008, so really quite contemporaneous. And I guess number one, these investigators have used the Crusade bleeding risk score and have certainly demonstrated in this large cohort that is a pretty good predictor of the extent of bleeding across this cross-section of patients. They surprisingly have identified that in this 400 hospital strong cohort that unfractionated heparin, our old friend, tends to be the most common anticoagulant still used. That being said, there are some paradoxes and perhaps some lessons learned that both from the standpoint of the readership and the audience and indeed even the investigators who participated, there may be some learnings going forward that would be useful. Paradoxically, low molecular weight heparin seemed to be used more commonly in older patients, patients with diminished renal function, and in females, which is the converse of what our trials tell us. So that was a little curious. And secondly, we recognized that the uptake of bivalirudin, perhaps not surprisingly given the publication of Acuity and Horizons during the time course of this data collection, that there's been a significant uptake in bivalirudin in both cohorts. But surprisingly, almost half of the patients were getting glycoprotein 2B3 inhibitors concomitantly, which is not certainly what clinical trials have told us is the right thing to do. So one wonders why that is, and one hopes that the message is because the commensurate increase in bleeding you would expect, losing the advantage that bivalirudin apparently would provide is undermined. The other, I guess, final lesson for me was that this troublesome issue of crossover, which Synergy identified first, that is, people getting low molecular weight heparin and switching to unfractionated or vice versa, is associated with an accelerated rate of bleeding. It also seems to be the case with bivalirudin, although the investigators haven't provided us with exactly which other anticoagulant was used, but this temptation to use more than one agent for reasons that are a little obscure, I think, is the other lesson associated with a diminishing return relative to the bleeding issue. As you'd understand, we don't have efficacy data, so at the moment I think what we've got is some signals, some red flares associated with what is associated with increased bleeding. There may be reasons behind some of these behavior patterns and indeed implications for the clinical efficacy that aren't collected, but I think that in a nutshell is pretty much the way I saw it.
So, terrific. I'd agree with that. So still heparin, unfractionated heparin, number one, a slight shift towards bivalirudin, and similar use of enoxaparin versus unfractionated heparin. But the final thing that impressed me is when they looked at predictors for bleeding, largely clinical characteristics of the patient rather than the drug being used. So we're going to close with that and appreciate your comments. Again, David Moliterno with Jack Cardiovascular Interventions. Thanks for joining us.